Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
Sepsis is the leading cause of mortality in hospitalized patients and affects millions of patients worldwide. In a recent episode of Critical Matters, we discussed the last version of Surviving Sepsis Guidelines. In today's episode, we will discuss sepsis beyond the guidelines. Our guest is Dr. Kalil, a physician specializing in critical care and infectious disease. Dr. Kalil is a professor in the Division of Infectious Disease and director of Transplant Infectious Disease at the University of Nebraska Medical Center. A renowned clinician, educator, and researcher, Dr. Kalil has received numerous distinctions, including the 2021 Scientist Laureate Award at the University of Nebraska Medical Center. Dr. Kalil is a prolific author and has participated in several IDSA, SCCM Clinical Guidelines, and has written extensively on critical care and infectious disease topics. He recently co-authored a wonderful seminar on sepsis published in The Lancet. Andre, welcome back to Critical Matters.
Thanks so much, Sergio. Always a great pleasure to be with you.
Well, we were discussing before the recording how it's important sometimes to dive a little bit deeper beyond guidelines into diseases and syndromes, and also talking about the importance of recognizing where there's opportunity for improvement, recognizing some of the shortcomings of trials, of evidence, of guidelines, but ultimately really being focused on building positive momentum to care better for our patients. So I would like to start with the whole concept of the sepsis syndrome. A lot of people have criticized it as being a syndrome. From my perspective, it's inadequate in some respects, yet it seems that it's a framework that is still needed and helpful. What are your thoughts on this?
Thanks for the question, Sergio. So we have to be realistic. There is no medical syndrome in any field, critical care, infectious disease, oncology, at any field that will be perfect, correct? It's the reason why we have syndromes is because, we are still lagging into understanding accurately the kind of the precision that we need in order to sometimes to tackle some of these challenges. However, the reason why we utilize syndromes is because with the syndromes we can narrow down the possibilities that are really critical for us to have a proper decision making at the bedside, and through the syndrome then we can kind of go further and try to understand exactly what's happening with each one of our patients. So it's clearly far from ideal. Sepsis syndrome has many issues in terms of lacking a specificity and being overly sensitive in many settings. But the reality is that if we're going to take at face value the syndrome and not really try to transport that syndrome to your patient population, where you live, where you practice, then likely the syndrome is going to be even less useful. So, correct? So I think we have to understand the limitations of the syndrome and utilize what can be of benefit to us and to our patients by utilizing the syndrome. So yeah, it is a flawed syndrome. It is a flawed definition like any syndrome. But without that, without that definition, without at least the basic definition, our job would be way more complicated and likely would be much less beneficial to patients. So I think this is a good start. It's a good beginning. And I think through that, we're going to talk a little more in the next 20, 30 minutes. And how can we go from that syndrome to make our diagnostics and our therapeutic more accurate to our patients. And so it is something that we are evolving, we are changing, we're improving. And honestly, the sepsis syndrome probably is going to be much changed, 5, 10 years from now, 20 years from now. And it's a good thing. It's a good thing because it means it's evolving and it's improving, and that's okay. So I think that's where we sit today. And I'm sure that we're going to just keep improving.
Without going into details into the multiple iterations of consensus guideline definitions, from a practical standpoint, Andre, how do you define sepsis?
From a practical standpoint, so we at this point, based on the sepsis 3 definition, it's, these are patients that we have a suspicion of infection, and we have a increasing or worsening of organ failure in conjunction with the suspicion of infection. Like sepsis 3 use the SOFA. Some countries like UK use NEWS2, so different scores. So the bottom line is, if you have somebody, and this is really important because nowadays in ICUs, we deal with a lot of patients with chronic pre-existing conditions, chronic organ failure. So, we admit, a large proportion of patients with chronic heart failure, chronic renal failure, chronic liver failure. And so this is a little different from like 20, 30 years ago, in which we didn't have, a lot of these patients didn't survive that long to make to the ICU. So we have today, because of the advances in medicine, we have patients surviving and with quality of life, despite the fact they have chronic organ failure or chronic immunosuppression, surviving post-cancer, chemotherapy, transplant, and so forth. So these patients actually will, they will have sometimes pre-existing organ failures. And this is important to mention because most of the sepsis definitions, including SOFA and NEWS, they are based on organ dysfunction. And so even though the organ dysfunction is important, you have to take into account that, what's the baseline organ dysfunction of these patients. And so let's say if you have somebody that lives with a chronic renal failure with a creatinine of 1.9, and the patient's coming to our ICU or to our ER with a suspicion of sepsis, in which we define a suspicion of infection with highly probable that the patient has a progressive organ dysfunction secondary to some immune dysregulation. You want to see a organ dysfunction that is above the baseline. Let's say if the patient had a creatinine of 1.9, you want to see somebody that's now is going to show a creatinine of 2.5 or 2.8, or if the patient had let's say a chronic lung failure, normally runs at home with let's say a nasal cannula of 2 liters, and the patient now comes to your hospital and the patient has has more hypoxia and is requiring a non-invasive or some other types of respiratory support that is much more than a patient was in their home. So these are the situations where I think that it's important for us to emphasize the change from baseline can be changed from no organ dysfunction. It can be changed from somebody that had organ dysfunction. So this is critical because otherwise we're going to be like fooling ourselves with patients that we believe that they have organ dysfunction related to the infection, but actually the organ dysfunction is just related to the baseline, physiological state of the patient. So this is why it is very important for us to kind of understand the definition in a way that we can put the patient perspective as well.
Excellent. So to summarize, really, it's thinking of infection and the presence of either new or worsening organ failure, which
yes.
As intensivist, I always would argue that our expertise is in managing multi-organ failure, so this should be right down our alley. In terms of epidemiology, Andre, any comments on the epidemiology at a worldwide basis, but also specifically in the U.S.?
Yeah, so the data, the data in the last few years keep coming and showing very clearly that we are dealing with close to 50 million cases a year, in the planet, and the mortality, something in the range of 10 to 12 million people, are dying from this. So the point is impressive how prevalent sepsis is all over the planet. What's interesting is that when you look at least the data based on this large electronic, medical records, electronic databases, we tend to see sometimes studies showing a increase in prevalence of sepsis in the U.S. With decreasing mortality, and some of the low middle income countries, we tend to see more data showing a decreasing rate of sepsis with still with a very high mortality. And so it's interesting how when you see these studies, you start thinking, okay, what's happening here? This is a little weird, we are seeing these discrepancies here. And yeah, I think that most of the discrepancies because the in the U.S. and in Canada and some of the Western European countries where we are now having a much better resources and much better infrastructure to take care of these patients. We are admitting patients to the ICU that actually have a higher risk of developing sepsis, patients that are survivor from, let's say from cancer chemotherapy, from transplants or some other, comorbidity or autoimmune disease. And so it's not unusual in the electronic medical records to see sometimes a higher description of sepsis, even though these are just patients that actually have a chronic medical illnesses and pre-existing disorders. So in some ways, it seems to me that most of the developed countries and the high-income countries, they have a inflation of the rate mostly related to the way that we're capturing this data, and in part because of the high tech and the long survival of some patients with autoimmunocompromise or comorbidities. So maybe it's a mix of both. In the low middle income countries, we are really lacking a lot of data. We really need more data, and I think this is a huge problem that we face all over the planet, because the lack of data end up leading us to make assumptions and making assumptions about specific large regions and countries gets very dicey and very dangerous. For instance, you can have way more heterogeneity in a low middle income country in ICUs. You can go from one ICU to the other in a matter of just 1 mile and see massive differences of resources of healthcare personnel in the ICU, technicians, nurses, and respiratory therapists, whatever. So the point is, we got to be careful when we make these comparisons, because part of the problem that we're facing today with the diversity of prevalence of sepsis and diversity of mortality, in part is related to the challenge of collecting this data, and in part is related to the incredible heterogeneity of resources and limitations that goes through different regions and different countries.
Excellent. In terms of why some patients with infections end up developing organ failure and sepsis and others don't, could you comment on the risk factors for this progression?
Yeah, no, it's very important, Sergio. I think that this is probably one of the most challenging factors that we have today, because we've developed a lot of really incredible technology in terms of trying to understand the pathophysiology of these patients. We are still in a beginning of the learning curve, but I think we are starting to understand much better the situation. So there are several factors here that are critical for us to understand who is going to progress to a more severe picture of sepsis and septic shock compared to who is not. So several factors. The number one that I want to bring is, and I brought this to a short editorial that I wrote with a couple of colleagues of mine for the intensive care medicine just last year. We titled as a subphenotypes and phenotypes as a way to reduce sepsis heterogeneity, hyperhope. That the editorial was trying to understand, who are how can we define which patients are really at higher or lower risk of developing and progressing this dysregulated kind of sepsis response? So the first thing that we comment, and I'll bring this, and we comment also in this sepsis paper in Lancet, is the microbial heterogeneity, correct? So the microbe, it's going to vary about the type. Let's say if you have sepsis from Staph aureus, likely going to have a different approach compared to sepsis from, let's say, E. coli. Why? Because Staph aureus is a bacteria that tends to have more metastatic infection, tends to have more organ invasion than, let's say, E. coli. So there's something particular about the bacteria, and so that the host will matter, but the bacteria has a very, very intrinsic properties that you have to put in perspective. The second thing on the microbe perspective is the burden, Sergio. And this is something that I'm dreaming of, is that we can develop techniques in which we can actually measure the burden of the infection at the diagnostic moment. So, nowadays you have, let's say you do like say PCRs, or we do blood cultures, and usually it's just, a qualitative process, correct? So you just have, okay, you have, let's say, E. coli sepsis or Klebsiella sepsis, and that's what you know, correct? So this is not enough for us. For us, being at the bedside in the ICU, we need to know the burden of this infection, because a patient that has, let's say, 100 million copies of Klebsiella pneumoniae in the blood will have a different progression of the natural history of sepsis compared to a patient that has 100,000 copies. And it's just this simple fact that the burden of the infection will change the host immune response, because when you have such a high burden of infection, becomes way more difficult for our immune system to deal with that, impressive burden, and that means we're going to become more vulnerable to develop and progress to septic shock. And I give an example: if you're a 25-year-old with, let's say, with a 10 million copies of Klebsiella in your blood, you're going to have a different answer compared to somebody that is 75-year-old with, chronic heart failure, hypertension, and chronic renal failure. Because again, it's simply the fact that if the host is dealing with the same amount of bugs, but the host already has some vulnerable immune dysfunction, this host is going to be way more vulnerable to progressive septic shock than somebody that does not have the same comorbidities. So the key point here is that the bacteria matters, the amount of bacteria matters. The host, as we just talked about, the host is going to be also critical to define the progression of sepsis. So if you have a host that is young, normally is going to have a robust immune response. It's normal, and it's expected than somebody that is much older, because we have something called immunosenescence. Immunosenescence is, the aging of our immune system. Every day that we wake up, our immune system is a little bit weaker, and that's progressive for the rest of our lives. There's no way back. And so the point is, the older we are, the more vulnerable we are to have progression of infection to sepsis and septic shock. If you have comorbidities that affect your immune system, and remember, you can have one organ failure. You don't need to have 2 or 3 or 4. You can have simply, let's make that very simple. You have one organ failure. All the other organs are perfect. Let's say, even though this is not unusual, because most people have some degree of multi-organ failure if they have one organ failure. But let's assume that you have specifically one organ failure. Remember, for every organ failure that you have a very defective immune system in that organ, because sometimes we forget that each one of our organs have actually different immune regulation. So we think about the immune system as a whole body immune system, but this is just one part of the scenario here, because you have to think that the kidneys and the hearts and the lungs, they have a very distinct immune defense, and they will be affected different from other organs. So this is the host perspective. And the last thing I want to talk about the host search, that's really important, because that's a huge part of my population, my hospital, my ICU, is the immunocompromised population. These patients that already have history of, let's say, solid organ transplant, stem cell, cancer chemotherapy, these patients will have way less manifestations of sepsis that normally we'd expect. They're going to progress in a much more silent way. I'll give an example. We had a couple of studies done in the past in here at University of Nebraska, in which we are trying to understand just kind of the clinical presentation of these patients, and turn out that most of these patients don't have any fever. They don't have even leukocytosis when they're immune compromised. So if you don't have leukocytosis, you don't have fever, likely the patient himself or herself is not going to be even aware that infection is progressing until they come to the hospital, and and then they get into the ER and they're in shock. Now we get called to see the patient in the ER, and the patient literally is in shock. You do a CBC, the white count is 6,000, temperature is normal. So, that's kind of go against the traditional teaching that you should have some signs of infection. A lot of times the signs are not there. So that means you have to be way more aware and have a much lower threshold to diagnose sepsis in these patients. And again, these patients will become more vulnerable, not only because they're going to have the lack of diagnosis in the early process, but also because they will not be able to stop even a burden of infection that's not that high, correct? So you don't need a huge burden of infection. You can have literally a quote unquote mild, urinary tract infection, end up in the ICU with 2 pressors, correct? So the point is, this is not even a high burden infection, but if you're that immune compromised, you have to put in perspective that there is no mild. So a mild UTI in a 35-year-old woman, it could be a disaster for a 35-year-old woman that has had, let's say, a stem cell transplant just a few months ago. So the point is, when you look at these patients at the bedside, you have to put in perspective the type of infection, the type of bacteria, the burden of the infection, and the host understanding at that moment who is your host, because once you connect the host with the source of the infection, you're going to be able to approach this patient in a much more individualized, in a much more accurate way. So I joke with my residents and my fellows that we are one of the rare, maybe the only specialists that actually have to treat 2 organisms at the same time. We have to treat the microorganism and the macroorganism, basically the human organism and the microbial organism. Because a lot of other, specialists, they treat one organ. Let's say a cardiologist treat the heart, your nephrologist treat the kidney. But if you work in the ICU with all these patients, you end up having to actually tackle 2 different organisms at the same time.
I like that. In terms of pathophysiology, Andre, we could obviously spend a long time talking about this and going deep. And you did mention already some of the impact of the host and the immune or the dysregulated immune response and its impact on different organs. Any other important current mechanisms, understanding of mechanisms that you want to mention?
Yeah. So, Sergio, I think that we are moving slowly towards a really trying to kind of subphenotype or endotype. There's all kinds of different terms. And if you ask people that really do a lot of the bench, they're going to have different definitions for this. So we as clinicians and clinician scientists, we tend to sometimes simplify these things. But the reality is, subphenotype, endotyping are ways to really, it basically brings some kind of biological signatures that will help us to be more accurate treating our patients. So I'll give an example of something that you've lived through and I lived through throughout this year. So sometimes you're going to have, let's say, patients with a septic shock with a massive coagulation disturbances. They're going to have, out of the blue, they're going to be very thrombocytopenic with a high PT and high INR. And if you can measure in your house, you can look for antithrombin 3 or protein C. They're going to be very low. So these patients are going to be like having a massive coagulation disturbances related to the sepsis. And these patients are probably going to be 20-30% of the patients that we see on a regular basis. But if you identify these patients early, likely we're going to tackle the pathophysiology of the coagulation as part of the immune defense, correct? So coagulation is part how we defend ourselves against these bugs. But if the coagulation gets completely dysregulated as part of our immune regulation, then we're going to have potentially alternatives, treatment alternatives that is going to be really focused on bringing a coagulation to a more regulated process. The same way, Sergio, now we know we have phenotypes, subphenotypes, study published in Lancet just recently, I think in March, April of this year, showing that maybe there are specific biomarkers at the bedside that can help us to understand which patients could benefit from immune modulation. I think this study was in Lancet Respiratory Medicine. They talked about potentially using a procalcitonin and interleukin 6 and STREM1 as 3 biomarkers that were predictive of progressing sepsis and potentially responding to immune modulation. So I think that, again, these are going to be trying to understand which of these patients have some degree of inflammatory dysregulation that can be amenable and can be like a treatable trait, as we say, something that can be treated with a very accurate, tools. So I think that the way we are seeing today, Sergio, is we are learning more about both the inflammatory and the coagulation cascades, and then some people are doing some work in metabolomics and proteomics. I think my hope is that understanding that pathophysiology the way we understand it today we're going to be able to develop treatments that are going to be very accurate for these specific regulations. Because, the old-fashioned approach of, giving steroids to everyone, giving whatever you have in your hands to everyone, likely, we're going to cause more damage than good, because we saw that. I mean, I think you remember, this is 20, 30 years ago when I remember when I was in medical school, people that had the label of sepsis in ICU literally were getting 1 to 2 grams of sulomedrol, and they're not even in shock. And that was the standard of care for many, many years, correct? So and because that was the physiology of the day. That was what people thought. That was the physiology of the day, correct? So everyone is inflamed. Everyone should get high-dose steroids. Another 10 years passed by with the randomized clinical trials to figure out that actually this high-dose sulomedrol or any high-dose steroids were being harmful, increasing mortality. And that was banned from most of the ICUs in the world until the early 2000s, with the French studies in which they start to look for low-dose steroids to see if that potentially in patients with septic shock, not only in patients with sepsis, and they start to kind of change the gear in terms of being a little more precise and trying to understand which patients potentially could have benefits from immunomodulation. But the point is, going with 1, 2 for everyone, we already learned that doesn't work. We already learned that can be harmful. And so, from here, forward, we're going to have to really be way more accurate, way more specific in understanding the pathophysiology to actually develop new treatments.
Perfect. And obviously, this also, when you look in hindsight, right, explains why applying these broad immunosuppressant or immunomodulatory therapies doesn't work in a large population of very heterogeneous, like you said, phenotypes and subphenotypes, and ultimately, like you said, moving towards understanding what's going on with each individual patient and trying to use a modulation of those responses might be the way of the future. But let's go back to the bedside and talk about some of the clinical interventions that we have to implement today to all our patients. And as I mentioned, we had a previous episode with a lot of the guidelines, but I want to get a little bit more of the nuanced interpretation from your perspective, Andre. And let's start with diagnosis. What's the role of biomarkers, and what is the current state of the art for diagnosis from your perspective?
Yeah, so Sergio, this is so critical. I mean, without good diagnosis, it's very hard for us to do what we need to do to improve, the survival of our patients. It's really important. And I'll give an example that I was in Europe just a few months ago in a meeting, and I was quite surprised to learn that actually there are many countries, and this is both in West and Eastern Europe, in which the microlab of these hospitals is outsourced in order to save costs. And we see that a little bit here in the U.S. in a very country, very community, very, like small areas in the countryside as well, because they don't have the means to have a microlab. I get it. You're in a small place, in a village or in a small city with, a few thousand people. They're going to have to outsource some of these tests. I totally understand. But I was very surprised to see that many of the European countries are outsourcing, even in places that have, high population density, in big cities. So what's the problem with this? The problem with this is, Sergio, that if you're going to send a blood culture to you suspect sepsis in your ER, in your ICU, and you send a blood culture, the blood culture is going to have to literally be in a bus or an airplane to another place. Right there, even if you have the proper bottles and the proper collection, you do everything correct. It's going to take hours for that sample to arrive in a lab, to be processed in the lab, because the lab is outside your hospital. And what I've noticed talking to people is that, and I've seen that in any place, including here in South America and Europe, is that the report of this outsourced micro lab is going to take much longer than if you had a lab in your hospital. So you say, well, what's the big deal? Well, the big deal is that people are having way longer time to have a result from a blood culture. It doesn't mean it could be sputum culture, could be a urinary culture, whatever it is, any simple. So the time that's taken is much longer. Second of all, what I've also been very impressed when I go out and talk about sepsis and utilization of, rapid utilization of antibiotics is that the time to blood culture positivity is not being reported in a lot of these outsourced labs. They just don't report. So let's say, you have a patient that, let's say you have a patient in ICU today with, with multiple lines in septic shock, very ill, and you don't know if the patient is septic because of a line infection or because of something else. You collect blood cultures from the lines, you collect blood cultures from a peripheral vein, as we actually indicate in the SCCM IDSA fever and fever guidelines that we already had a podcast together before about this. Very important to know the time to positivity, because that helps you to understand if it is a situation in which the line has to be removed or not. You're not going to have. They're going to just report whenever the culture turns positive. You're not going to have. People don't have even that kind of very basic, simple thing that you do if you had a microlab in a hospital. So I think we have to emphasize, Sergio, that the fundamentals didn't change. The fundamentals are you need a rapid and precise diagnosis of the infection. This is never going to change. This is never, ever going to change. And I bring that to every meeting I talk about. You have to make the efforts to have a microlab that's going to be responsive to you. If it is a microlab in your hospital, if it is outsourced, you have to have the quick access to the results, and you have to understand how long it's taking for these cultures to grow. So that's the first thing. And we are talking about burden of infection, Sergio. I mean, I'm just last week I had a patient that literally it grew Enterobacter in 5 hours after collecting blood culture in the yard before even a patient hit the ICU. 5 hours was positive. The patient, you could clearly, went fast septic shock. I mean, it's that, that this is a situation where the patient had a very high burden of infection that, it made the entire team, the ICU team, the yard team, to be much more aggressive and responsive to the situation than somebody that, maybe is going to take 24 hours to grow something because of a low bacterial burden. So all these things are very important. Now, talking about biomarkers, because, we could talk forever, but I'll try to just in a couple of minutes bring a little bit of what we have today. So today is still pretty much, I would say that, the things that we have in our arsenal, most of the places, not every place, but most of the places are going to be white blood count, with a differential, neutrophils, bands, and so forth, and platelets. So a CBC, and that's still very important, still useful. Not alone doing anything, but very important as a complement. You're going to have a lactate, as as is indicated by the Surviving Sepsis Guideline. But remember, very important, lactate, can be elevated for many, many reasons other than hyperperfusion, other than shock. So if you do not really try to understand the potential reasons for lactic acidosis, you may end up treating hyperperfusion when the patient does not have hyperperfusion, correct? So this is, and potentially you're going to cause harm to the patient by giving more fluids and more pressors. So lactate alone is not a great tool. Lactate has to be in the context of what is the clinical situation and what are the potential reasons for having lactate elevation other than hyperperfusion. Very, very important. A third of the patients can have lactate elevation without shock, and a third of the patients can have septic shock without any lactate elevation. You can have actually a no lactate elevation and being in severe septic shock from infection. So again, it is alone is not going to do much for you. And then the other two biomarkers that are used differently in different countries, the C-reactive protein and the procalcitonin. Both are, if they are normal when you're seeing the patient at the bedside, they're useless. They don't do anything for you because they can be normal in patients with a severe infection and even severe septic shock. So the first CRP, the first procal that you're going to do, it can simply, basically reveal that the marker did not have enough time to elevate to be to a level where it can, be useful at the bedside. what these biomarkers can help, the same with lactates, the same with Procal, the same with the CRP, is that you measure serially, correct? So you wanna make several measurements of these biomarkers to try to understand the trend of these biomarkers. If you see a lactate going up and up without stopping, it's gonna be much more informative than a lactate that is not changed at all. The same with the Procal, the same with the CRP. So understanding the kinetics of these biomarkers and how the kinetics really inform you at the bedside, it's critical. So I think the lesson of the biomarkers today is that they have to really be they have to be in the context of the situation that you are for each one of these patients. If you simplify the biomarkers by just calling, normal and abnormal, likely you're going to miss the diagnosis, or you're going to be treating things that actually are non-infection, that are elevating some of these biomarkers and that require a different treatment. So biomarkers, even if we develop, let's say, surgeon, very great tools, very specific biological signatures, different tools. Remember, biology is overlaps a lot. So you can have IL-6 elevation, you can have all these biomarkers, cytokine elevation for reasons that are infection as well. So even when we reach the point to have some of these phenotypes at the bedside, what I think is going to be marvelous, still that's going to require us clinicians to actually put in the context of each one of our patients. If we don't do that, likely we're not going to make the progress that we should.
Perfect. As we move into management, I want to focus on antibiotics. Mm-hmm. And really what I would like to hear, Andre, is your approach to a rational antibiotic use. And the two things that I'm always trying to balance is how broad and how quick. And based on what do you make those decisions?
So, Sergio, the thing that got me really it kind of changed my mind dramatically about the use of antibiotics was in 2015. I know that sounds like too long ago when we talk about these years. 2015, we published a study in which me and a couple of my ICU colleagues here in a statistician tried to understand the differences between early go therapy, the difference between observational studies and RCTs, because in 2015, it was just a year or two after the ARISE and the process trials were published, and the promise were 3 RCTs that basically did not show benefits of early go therapy. So the goal of the study was just try to understand what was happening with early go in the 2000s and why the observational studies were so positive from the first 2001, the Many River study, and the 3 RCTs done 10 years later were flat negative. And so it was much more a scientific curiosity. We're trying to understand what was different. So we dissect each one of the studies, the RCTs, the observation studies, and try to understand if the hemodynamics, the amount of fluids, the amount of hypoxia, and the response to the fluids and pressure, the whole thing, correct? So hemodynamics and antibiotics, we look for everything, blood transfusion, vasopressors. So with literally with over 10,000 patients looking into all this, we found something that was a complete surprise, that the observation studies that had the usual, the pre and post. So in my ICU, before I start early go and after early go, the survival was improved, but the RCTs didn't improve. We found that the only thing that justified the difference between observation studies and RCT was time to antibiotics. So in the observation studies, the time to initiation of antibiotics, it was significantly shorter, faster, when they provide the bundle, the early go bundle. So compared to before when the ICU didn't have that. And in the RCTs, the time to initiation of antibiotics was identical between control and the early go and bundle arms. So in the RCTs, they didn't show mortality difference because time to antibiotics was identical. In the observation studies, it showed improved survival with the early go simply because the antibiotics were given early. So that to me it was a shift change for me in 2015 because I realized as an infectious disease and a critical care doc, I always believed antibiotics were super important. But after 2015, I realized that they're more than super important. They are uber important. So it's really impressive. So, and what we learned in the last 10 years, Sergio, is that actually, the speed is critical. The spectrum is going to be really based on where you live, right? So if you live, I'll give an example, right? I'll give one example last week, I had a patient that had a infection. Basically, we had a rapid diagnosis. The culture grew fast. We had the PCR of the culture, and we had a suspicion that this patient had a specific microorganism, a specific bacteria that, based on our University of Nebraska antibiogram, it is a bug that normally tends to be resistant to the usual antibiotics that you use for the empiric cover for sepsis and septic shock. So with knowing that bug and knowing the antibiogram of my hospital in my ICUs, I was able to say, you know what, I'm going to have to be broader than usual. I'm going to have to be more aggressive than usual because if it is the bug that normally we see at my hospital, at my ICU, I may end up missing the treatment if I just use the standard antibiotics that normally use, and was the right decision to do because it turns out that the bug that grew was a little more resistant than we expected based on the antibiogram. So why I'm saying that, Sergio, because I really believe that being broad when you have understanding of your biome in your hospital, in your ICU, you have a nice understanding of your ecology, it makes much more sense. If you live in an area with no resistance to, a lot of these antibiotics, like let's say some of the Nordic countries have very low resistance to, let's say, pneumococcus, they tend to be sensitive to penicillin. A lot of if you go in the ICU in some of the Nordic countries, they're treating pneumococcal sepsis with penicillin. If you come to Nebraska, if you come to the U.S., you can't, and most, because if somebody is that ill with septic shock or pneumococcus, chances are that penicillin is not gonna cut the deal because they're going to be resistant. So we live in an area in which you have a different ecology. So understanding your ecology is going to make you much more accurate about how aggressive you're going to be in the broad, in the spectrum of antibiotics. But the initiation to me is critical. For every hour. In the same study that I mentioned to you in 2015, we noticed that for every hour that we delay antibiotics in patient with septic shock, the mortality was pretty much going up in relative terms, in terms of 8-10%, was very similar to the Kumar study done in 2006 in Canada. So again, different studies, different populations, 10 years later, same results. So the bottom line is septic shock, and in which you have a high suspicion of infection. For every hour that you delay your antibiotics, you're going to really increase significantly mortality of your patients. So it's really important. When it comes to severe sepsis, well, we don't call more severe sepsis. When it comes to sepsis without shock, and this is what, the guidelines, the Surviving Sepsis, what I agree with the guidelines is that, you have a little more time for diagnosis. You have a little more time to just, kind of be aggressive with your antibiotic because you don't know even if the patient has infection. So go ahead and try to get some tests that are going to help you to understand. Let's say if you suspect maybe the patient has pulmonary embolism or the patient has some other non-infectious disease, do some other tests, do like an angiogram, whatever you believe that's going to be important before you just give like tons of antibiotics to a patient. Because remember, giving antibiotics to the patient without having a proper diagnosis has two major harmful effects. One is that you may miss the diagnosis that actually could kill the patient. Let's say if the patient has a pulmonary embolism, you're treating pneumonia, the patient is not, the patient likely is not going to survive, is not going to do well if you give antibiotics. Antibiotics are not going to treat pulmonary embolism, right? Second of all, the antibiotics have side effects. Major side effects can be an issue for a patient, especially if the patient is critically ill. So you may give side effects and you may not treat the actually etiology of the shock of the patient. So that's why it's very important if the patient is not critically, it's not that critically ill, you have a little time, the patient's not in shock yet, and you're not clear if this patient has infection, you can definitely spend another 2 or 3 hours, 4 hours trying to understand more if it is a situation in which you should use empiric antibiotics or not. So I think that's a reasonable recommendation from the guidelines, and I do agree that in practice.
And as a rule of thumb for our audience, the way I interpret all this is beyond what the guidelines say and some of the arguments and pushback on time. The reality is that the sicker your patient is, the quicker you have to intervene with antibiotics, and the lower your certainty of having an infection is going to be accepted. On the other hand, when you start the antibiotics, right, again, think about the source of infection. Where do you think the infection's from? Think about the individual patient, like you mentioned earlier, the host characteristics, and understand your antibiogram. And I do believe that's a point worth emphasizing, Andre, because with your ID hat, you live and die by the antibiogram. But I would argue that a lot of our critical care colleagues, including myself, are not as familiar or don't use their antibiograms to the full of its potential at their ICUs.
I agree 100% with you, Sergio. I mean, you're making a very good point. I think that, I think it is something that's missing in a lot of ICUs is the more objective understanding of the utilization of antibiograms. So what we do here, we have every 6 months we update our antibiogram here, and we have little pocket, like little pocket things, just literally just put in your lab coat and you carry with you 24/7. It's just a very small little thing in which you just open and you see the bug and you see the antibiogram in front of you. So that stuff to me, it's marvelous. And to me, it's something that should be done in every single ICU, in every single place in this planet. But I know we are far from reaching that. But I think, the fact that we're still not there doesn't mean that you shouldn't be there. So I think we should keep aiming to have this more widespread.
Excellent. As we move forward and try to close, Andre, we're not going to talk about hemodynamic support. That's, I think, a story for another day. But I really wanted to hit on the antibiotic discussion. Any comments on source control?
Yeah. So, Sergio, I'm glad you brought this up, Sergio, because sometimes we get so focused on antibiotics and we really cannot forget the source control, because the source control means it's a great way for you to understand the burden of the infection, correct? So let's say if you have somebody with a large intra-abdominal abscess as a likely source of the sepsis or the septic shock, you can give all antibiotics in the world. You can give the broadest and the fastest antibiotics in the world. All you're going to do is potentially minimize the spread of the infection, but you're not going to be able to eradicate the infection, correct? So you have to drain that abscess, because most antibiotics are going to have a very hard time to reach levels inside the abscess that are going to be able to eliminate that infection. So there are plenty of studies showing today, I'd say in the last 10 years, there are plenty of studies showing that the adequate and the timely control of the source impacts in the survival for patients with sepsis and septic shock. So the way I try always to think is, okay, I'm being pretty smart about choosing the antibiotics and timing the antibiotics, and I have to be as smart as controlling the source. If the source requires some kind of device removal, line removal, I'll give an example. I remember like today, Sergio, it was about a year ago. It was Saturday night, it was 10 p.m. when I got called to see a patient on the floor that had Staph aureus bacteremia, and the patient was already in 2 vasopressors who have been transferred to the ICU, and the patient had a dialysis catheter. It was Saturday, 10 p.m. It was a permanent catheter, and let me tell you, I said, we're gonna have to remove this catheter, and because the patient was a young patient, septic shock, very ill, and I remember like today, at the moment we got that catheter out, you could count, it was a linear progression of decreasing vasopressors, decreasing fluids. By the morning, Sunday morning, she was off everything, and so these things are dramatic because this is what it is. It was a patient that really needed a source control. If that line was not removed on Saturday night, it's very possible it shouldn't survive through the Sunday. The burden of the infection was too high. So absolutely with you, Sergio. I'm glad you brought this up, because I think source control has to be at the same level of choice of antibiotics when it comes to controlling sepsis and septic shock.
Excellent. Well, Andre, you've been on the podcast before, and as we close, you know that we like to ask a couple of questions unrelated to the clinical topic. Obviously, there's a lot more we can talk about sepsis, and we definitely will have you back on the podcast to talk about this and other topics. But I would like to ask you about books. We talked about books last time, but have there been any other books that you've read recently that have an impact on you?
It's. I'll tell you something, interesting. Usually, I try to always thinking about reading new books, but a few weeks ago, I decided to. When you go through your little library at home and you start to look for, just things, just to change a little bit gears, and I found an old book. I'm not sure how old it is, but I brought it because I thought it was fascinating. I think it was published in. Let me see. I'll give you the date, Sergio. It was published in 2014. Interesting. I decided to reread this book. It's a book called Curious, and the title is Curious, and it says the desire to know and why your future depends on it. And the author is called Ian Leslie, Ian Leslie, Leslie. It's a fascinating book. I'm rereading. I'm just halfway through again, and I read about 11 years ago. And I'm going to read, just, if you don't mind, just for 30 seconds, I'm going to read a couple of sentences from the book because it illustrates the beauty of what the book tries to say.
Perfect.
It says, so it says the attraction to this attraction to everything novel is what the scientists who studied call diversive curiosity. Diversive curiosity is essential to exploring mind. When you get, you see headlines and tweets and blog posts and apps and new things and news and, it's all these flashy things. Everything is, around us. And again, this book is 11 years old. I mean, so today we have way more, kind of a diverse ways to to get to know things. So diversive curiosity is essential to an exploring mind. It opens our eyes to new and undiscovered, encouraging us to seek out new experiences and meet new people. But unless it's allowed to deepen and mature, it can become a futile waste of energy and time, dragging us from one object of attention to another without reaping insight from any. Unfettered curiosity is wonderful. Unchanneled curiosity is not. When diversity curiosity is entrained, when it's transformed into a quest for knowledge and understanding, it nourishes. This deeper, more disciplined and effortful type of curiosity is called epistemic curiosity. And it is this that I want to bring to you, Sergio, because epistemic curiosity is that kind of deepened curiosity that we all just crave to know more, to learn more, it's kind of when we talk to each other, to know about each other, when we talk to our patients, when we read a book, when we try to understand the pathophysiology of the disease, all these things that just trigger this great feeling on us of earning, of learning, of being even more curious because you just read something that triggers something so exciting to you. So that's why I'm bringing to you. I think this is how we can be better clinicians, how we can be better scientists. Is just being curious is a huge deal, and I do praise that, and that's why I went back and I'm rereading this book.
I love it, and I really, in today's age where everything seems to be sound bites, TikToks, and posts, I always say that having a broad curiosity obviously is important, but also remind ourselves that going deep sometimes is extremely valuable as well. And I think, Andre, this is a great reflection. I was going to ask you about what would you want to leave with our audience, but I think this is perfect and a perfect place to stop. I really appreciate your time, your expertise. And like I said earlier, I look forward to having you back on the podcast.
Thanks so much for the invitation, Sergio. It was a pleasure always talking to you. I learned a lot, through our conversation as well. And good luck with everything. Thank you.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.